Hello everyone, good evening. Today we will discuss about interesting topic which is very not easy to understand, maybe few difficulties especially for postgraduates and all. So like approach to pediatric cardiac emergencies. Cardiac emergencies can present especially to ER room or in PICU or at a home scenario, and duration, the onset of presentation may be at immediately after birth or at a neonatal period or in infancy or at a pediatric age group. There is a wide spectrum where the etiology pertaining starting with the heart, which present as emergency situations. So yes, cardiac emergencies are a bit different from normal regular pediatric emergencies. So how do they differ? And because what is usually normally recommended in a normal pediatric emergency may be contraindicated in it if it is a cardiac emergency. So especially a practicing pediatrician or a postgraduate definitely should know the difference, how to differentiate this is a cardiac emergency or this is a non-cardiac emergency. So that differentiation has to be known. So we will deal this topic in two sessions, especially because this is a wide topic and needs to be discussed in detail. We divided it in two sessions which we discuss. So this is the part one which we will discuss today, and we will come up soon with part two also. So especially in this part one, we will try to deal with topics like emergencies which present at birth, or emergencies which present in neonatal period or in childhood period, and congenital heart diseases, how do they present as emergencies to the ER in pediatrics, and heart failure and arrhythmias. We will try to cover these topics in the this part one session. So yes, so reasons for undiagnosed congenital heart disease at birth. So why congenital heart diseases are usually undiagnosed at birth? Why most of the time we will be diagnosed them only after the birth? Because lack of prenatal diagnosis, no poor prenatal care. Most of the ultrasound diagnostic test even done prenatally may fail to pick up that congenital heart diseases. Maybe that it because they all are subjective. It's not anything objective. So that subjective perspective, the radiologist performing and the resolution of the images and the machine which has been performed, lot of things may take place, or any failure to use even pulse oximetry, because we see most of the centers government centers or whatever even lack this pulse oximetry checking, especially in pediatric age group after birth and home birth scenarios. So yes, most cardiac emergencies due to congenital heart diseases in undiagnosed children most often present in neonates, infants less than 1 year. So yes, when they come to emergency, especially cardiac emergencies due to congenital heart diseases, most commonly they present in either neonates or present in infants less than 1 year of age. Then emergency presentations. So yes, definitely. So emergency presentation of heart diseases can be broadly classified predominantly into three different manifestations which they manifest as, like respiratory distress, shock, or cyanosis. So yes, so how the manifestations and what is the pathophysiology and what is the underlying etiology. When we see like respiratory distress, yes, definitely any respiratory distress, it need not be cardiac, even it could be respiratory cause also. So when somebody practicing pediatrician need not have exactly, if somebody comes with respiratory distress, he needs to differentiate whether this is due to cardiac or whether this is due to respiratory. So yes, so respiratory distress will be tachypnea, retractions, wheeze, or grunting. So always remember, this need not be a respiratory case, this can be a very well cardiac case also. So this tachypnea, retractions, wheeze, grunting is usually accompanied with metabolic acidosis, respiratory alkalosis because of tachypnea, washout. So the underlying pathophysiology, what could be? Because of the pulmonary edema, cardiac origin pulmonary edema, airway obstruction, or anxiety because of that. So this is, then next comes shock. So shock, yes, definitely cardiac origin emergencies, child landing up in shock, yes, can present. Features of shock: tachycardia, poor perfusion, hypotension. This can be very well present in hypovolemic shock, septic shock, and even cardiogenic shock. Yeah, all of them are there. Decreased cardiac output. So this cardiogenic shock presentation could be probably due to impaired myocardial contractility or any obstructive lesions like coaction of aorta, or some duct dependent lesion where duct is closing within newborn period, or else like increased afterload. So it can be due to. Whereas cyanosis, yes, a child or a neonate or a newborn when present with cyanosis, especially central cyanosis, suspect cardiac origin. because of central cyanosis, because of hypoxemia, where shunt goes from left to right to left of the heart. So right desaturated blood, when it mix with left side 100% saturation blood, there will be a mixing of the thing, and ultimately the child will be cyanosed. Then cardiogenic shock, usually diagnostic pitfalls. Yes, most present with respiratory distress. They are misdiagnosed as asthma, bronchiolitis, and pneumonia. And early manifestations of pulmonary edema are usually missed, which is wheezing and hyperinflation. Usually misdiagnosed as respiratory. Keep on giving nebulization, no improvement. Then treating with bronchodilator worsens clinical status. Yes, this is the most important pitfall. Why? Because if it is a respiratory wheeze, if you give bronchodilator, definitely that will improve. Whereas if it is a cardiogenic wheeze, cardiac wheeze, if you give bronchodilator, what will happen? Beta agonist, it will just cause tachycardia. Already there is cardiogenic decompensation phase and you are trying to increase the heart rate. It worsens the clinical stage. Then apparent dehydration leads to inappropriate fluid expansion. So already you see child may appear dehydrated, but he may be innerly, he may be fluid overloaded, his heart may be failing, he may be having huge hepatomegaly. If you don't palpate, you will miss it. You tend to give fluid, thinking array he is having cold extremities, he may be having shock, you may feel, and try to push the bolus, but already he may be having massive hepatomegaly. Then lack of obvious findings such as JVP distension. Yeah, sometimes when you fail to observe those like increased JVP or hepatomegaly, you tend to misdiagnose. Then shock stage is often blamed as sepsis, especially neonates. Yeah, whenever somebody neonate, some neonate randomly born in peripheral center or some district level center comes with cold extremities, poor pulses, lethargic, dull activity, most first diagnosis will be septic shock. Septic shock, you will be always thinking, but always keep in mind, why septic shock? Why blame sepsis? Is it really any cardiac? Is it really child is having any congenital heart disease? This thought should always be there, just to rule out cardiac thing before you tend to keep give piptas de do amikacin de do. Before you think of loading or dumping with antibiotics and just blaming as sepsis, first try to rule out cardiac thing. Then metabolic acidosis is blamed or hypovolemic stasis is blamed. Then lack of cardiomegaly on chest x-ray in early stages of myocarditis. Yeah, this is one more pitfall. Most of the pediatricians tend to feel that cardiac means for them there should be cardiomegaly. It need not be always. Cardiac emergencies or neonates or children presenting with cardiac complaints in emergency, cardiomegaly is not a dictum. There need not be cardiomegaly for every cardiac emergency. So just don't keep in mind x-ray heart shadow appears normal, it doesn't look like cardiac. No, that's not. Just you based on cardiomegaly don't decide whether this is a cardiac or respiratory. Then early neonatal period, what are the cardiac diseases which we manifest? Yes, so the more it is usually we divided it as left sided, right sided obstructive lesions and systemic AV fistulas. Yes, definitely vein of Galen aneurysms or some liver aneurysms, usually which there is a systemic arteriovenous shunting fistulas, hyperdynamic circulation, and they land up in shock. They present in early neonatal period, usually day 1, day 2, day 3. Yeah, then left sided obstructive lesions. Yes, so what happens? Left sided predominantly, the where we divided right side and left sided is RA and RV as right sided and LA LV as left sided. So left sided obstructive lesions lead to systemic hypoperfusion, because yeah, left side we has to go to aorta, there is no blood flowing there, there is obstruction, the systemic circulation lands in hypoperfusion. What are the conditions which can cause this left sided obstructive lesions? Yes, it is hypoplastic left heart syndrome, critical aortic stenosis, or interrupted aortic arch. Then right-sided obstructive heart lesions. Right-sided obstructive heart lesions, how do they present? Because right side is obstructed, there is no blood flow into the lungs, so lungs are completely devoid of blood flow, so there is no rebound oxygenation, so there is only mixing of that desaturated and whatever blood, so there is central cyanosis. So what are the right side obstructive present lesions which present in early needle? Complete tricuspid atresia, hypoplastic right heart syndrome, or complete pulmonary atresia. Yes, because there is complete closure. Blood can't go into lungs at all. Only here the dependent of lungs is usually through duct dependent lung flow. See, basically, yeah, that's why they present in early neonatal period. So whatever these left sided obstructive lesions, the systemic perfusion is solely dependent on ductus. even in right-sided obstructive lesions, the pulmonary circulation is solely dependent on ductus. So this is the thing which we should understand. Why these all so-called conditions are presenting in early neonatal period? Very simple. All these are just dependent on ductus. The moment birth happens, child comes out of the mother, the ductus arteriosus tries to get closed because of the oxygenation or baby crying, getting exposure to more thing. So and the circulation, maternal circulation is going to be changed from normal circulation. So the ductus once gets closed, so these all are ductus dependent systemic circulation, ductus dependent pulmonary circulation, they suffer. So once duct is closed, they present in emergencies. So early infancy, then we go to a little late, not like immediately neonatal period. They sustain for some 4 weeks, 6 weeks, and like within 3 months they present. What are these? They are like left to right shunt lesions or Al-Kappa. Al-Kappa is anomalous origin of left coronary artery from pulmonary artery. So what happens basically? Usually coronary arteries are to be supposed to arise from aorta because it is 100% saturation blood which has to supply to the myocardium. But what if it is arising from pulmonary artery? You see, pulmonary artery is completely arising from right ventricle, which is completely desaturated blood. So if coronary artery is arising from pulmonary artery and that blood is going to supply all the myocardium, myocardium suffers obviously. So it is where pulmonary vascular resistance, pulmonary arterial pressures fall below critical level. Anomalous fails to perfuse the myocardium. So obviously the child lands up in shock, failure. So left to heart right shunts are usually can be like three: VSD, ASD, PDA, where blood flows from left to right. So right to left, if it is duct dependent lesions, yeah, they present early. Whereas left to right, yes, they can take time to present. So clinical manifestations include respiratory distress, tachycardia. Why? Because blood is always flowing from left to right, left to right. So RV is getting huge blood both from RA and from even LV, and this blood is going to lungs. So pulmonary circulation becomes more than systemic circulation here, isn't it? And because LV is not only pumping to aorta but also pumping certain blood into RV. So systemic circulation becomes less, QS becomes less, and QP becomes more. So once QP becomes more than QS and QP-QS ratio becomes more than 2:1, they'll end up in emergencies. So this is like age specific lesions and most common emergency presentations. Yes, definitely. So as we discussed already, this is a tabular format which is describing like who present within newborn period, like tricuspid atresia, pulmonary atresia, Epstein's anomaly, DTGA, and double outlet right ventricle with severe pulmonary stenosis and all. So conditions present because these all are like duct dependent conditions. And newborn, duct dependent systemic blood flow lesions. These all are duct dependent pulmonary blood flow lesions. So what are duct dependent systemic blood flow lesions? Aortic atresia, interrupted aortic arch, double outlet right ventricle with aortic stenosis, critical aortic stenosis. These are all present with hypoperfusion, shock. So see, duct dependent pulmonary flow regions are always presenting as cyanosis because there is no oxygen in lungs. Whereas duct dependent systemic blood flow lesions present as hypoperfusion, shock, because there is no blood flow coming to the aorta. Then young infants, they are VSD, ASD, PDA. Yes, these all present with like pulmonary edema, crepitation, tachypnea. These all features. Then Al-Kappa presents with shock. This is clearly Al-Kappa presents like you can compare Al-Kappa with myocardial infarction in adults. You can't exactly compare, but that's how the pathophysiology happens to be like, because see, myocardium is receiving very desaturated blood and oxygen is not sufficient. What happens to myocardium? It suffers, it goes. That's even Al-Kappa ECG. If you see ST elevations, T wave depressions, pathological Q waves. So it's like MI, it's almost like MI, somebody suffering a heart attack, chest pain. So it's almost equivalent to that. Then risk of commonly employed treatment strategies. So yes, this is what we discussed in the starting. Normal emergencies differ from cardiac emergencies. Here we see a set of treatment guidelines which are very frequently used in normal emergencies. but all of them can be potentially detriment in case of cardiac emergencies. If you see somebody, child coming to the present ER room, tachypnea, immediate what the pediatrician practicing pediatrician first go will be start oxygen, start oxygen. But you see, if it is a cardiac emergency, if you give oxygen, there are chances that you may cause more harm than the need. Because see what happens, oxygen is a potential pulmonary vasodilator. Everybody agree with that. It is a systemic vasoconstrictor and pulmonary vasodilator. So the moment once you give oxygen, pulmonary vasodilation happens. Suppose if the child is already QP more than QS situation, it worsens pulmonary edema because already fluid overload. Then pulmonary circulation still happens completely. So more left to right shunting happens. Then ultimately what happens? Peripheral vasoconstriction and increased afterload. Child becomes more shock. Shock is worsened. So always think of somebody deteriorating even with oxygen. Is this a cardiac thing which is underlying? Then fluid bolus. This is another thing which we usually use very rampantly in ER. Somebody having very poor feeble pulses or cold extremities. They do 10 ml per kg fluid bolus. But fluid bolus worsens pulmonary edema. Again, QP more than QS situation. You give again fluid. It increases pulmonary edema. So and again causes decreased coronary perfusion. It is also detrimental. Then another thing, one more, albuterol, asthalin, salbutamol, like somebody having tachypnea, baby coming with wheeze, usual like practitioner will be, de do CVOL, ek do nebulization laga do, salbutamol nebulization de do. But what happens if it is a cardiogenic wheeze? Yeah, it's right, you heard wheeze in the chest, but you have to differentiate it is a cardiogenic wheeze or respiratory wheeze. The moment you hear wheeze, if you give straight away salbutamol and within next moment you see child becoming more tachycardia and systemic signs are increasing and saturation and all not improving. Yes, that is because probably he is having cardiogenic wheeze, and for a cardiogenic myocardial which is already failing, you tend to, so it is beta agonist, just it increases the heart rate. So you will worsen the tachypnea and you will worsen the metabolic acidosis. Then furosemide. So furosemide, yes, somebody again feeling like probably maybe fluid overload and all. If you try to give off some Lasix straight away in the ER, it may worsen relative hypovolemia. So always, even giving fluid administration, you have to be very cautious. Just go with 5 ml per kg. That too very slow, not like push. Like in emergencies, 10 ml per kg push rapid. No, don't do it in cardiac. Use only 5 ml per kg. Give slowly over 20 to 30 minutes. Just watch for his chest crepitations. Check out his hepatomegaly. Check other parameters like how BP is improving, how heart rate is changing. This is how you go. Then, duct-dependent lesion should be always considered in all neonates presenting in shock or cyanosis in neonatal period. Exactly, like what we said. It can be cyanosis, like duct-dependent pulmonary circulation, or it can be shock, duct-dependent systemic circulation. But always keep in mind, just don't go as sepsis, RDS, respiratory distress, or always think cardiac, can be cardiac also. So that's where duct-dependent lesion should be thought of. So yes, this prostaglandin PG, even alprostadil, is very easily available in most of the centers. Even most of the pharmaceuticals are nowadays coming up with provision of this drug, a very wonderful drug. So it just keeps that duct open at least till the child reaches cardiac center, till a pediatric cardiologist arrives and go for a complete 2D echo screening and give a decision. This can be used. So this is a very drug which always people should be trying to use it whenever there is a sudden child landing up in emergency, cyanosis, newborn especially newborn. Whereas foramen dependent lesions are like TGV and obstructed TAPVR, like transposition of great veins and obstructed TAPVR may need balloon atrial septostomy. Yes, definitely. You see, because obstructed total anonymous pulmonary venous return, all the pulmonary venous return is coming to the right side, and how this right side is supposed to, this blood is supposed to go to left side. There should be some communication between right and left, isn't it? If there is no communication, suppose all the atrial septum and ventricular septum are intact, and all your pulmonary veins are coming and landing up in right ventricle, how your left atrium is going to receive blood? Where from it is going to receive blood? If there is no blood in left atrium, how your left ventricle is going to pump to systemic circulation? So there has to be some communication in the interatrial septum or interventricular septum, so that this left side of the heart receives some blood, isn't it? So suppose in case by chance the anatomy develops in fetal period in such a way that there is no such a thing and all the septa are intact, the child definitely lands up in shock on day one, remember, because there is no blood coming to the left side at all. RA, RV, lungs, and again to RV. Total anomalous pulmonary venous return to right side. So there is no blood going to left side. So these children need immediate emergency balloon atrial septostomy. So this is not something duct dependent even. So yeah, certain part of duct may provide from RV, it goes to pulmonary artery, and from there it goes to right to left, and systemic perfusion may be maintained. So child may be somehow thriving to live, but it can't go for a long time. So definitely they need BAS, balloon atrial septostomy. So yes, definitely we need to keep in mind these sort of scenarios. And another point is all patients with suspected congenital cyanotic heart diseases should be referred to tertiary care centers. Don't try to manage them at secondary centers, because they definitely are going to be very sick, and the ultimate goal is just try to keep them maintained till they reach that tertiary center. Then, like as we told, right obstructive lesions are blue cyanotic, whereas left obstructive lesions are gray shock, isn't it? Because right obstruction is no blood into lungs, so they are cyanotic, blue, and left obstructive lesions are no systemic perfusion, so they are shock, gray. So these are the diagrammatic depictions how they go. So gray baby shock, blue baby cyanotic. This is left, this is right obstruction. Whereas pink baby heart failure happens in more than 1 month to 6 months. This is due to shunts, ASD, VSD, PD. Then heart failure. So heart failure, there is no formal definition for heart failure in children. So like classification, usually it is class 1, class 2, because NYHA classification, respiratory distress and all, they are there for adults and all. But for heart failure in pediatrics, what most commonly used is ROS and revised ROS, which was there before. Causes of heart failure in children. Yes, heart failure in children, usually neonates and infants. It can be congenital heart diseases, obstructive lesions, aortic stenosis. Then after closure of PDA, volume overload, left to right shunts, valvular dysfunctions, semilunar valves, pulmonary hypertensions. Yes, but this is definitely right ventricular failure. So always remember, pulmonary hypertension is a life-threatening situations where child lands up in severe right ventricular failure, because there is severe pulmonary hypertension. Your right ventricle can't pump the blood into the pulmonary aorta. It suffers a lot, so it lands in failure because there is a lot of thick musculature. It is very tight pulmonary artery, and right ventricle can't generate that pressure. Sometimes, in severe pulmonary hypertension, your pulmonary pressures may be more than the systemic pressures. Suppose your systemic blood pressure in a newborn may be some 60/30, and your pulmonary artery pressures may land up in 80/40. So your RV can't pump to that stage, and RV just fails and child collapses. Cardiac arrest may happen. Then other causes which can present in infants like Kawasaki, myocarditis, arrhythmias, and endocrine causes like hypothyroidism, hypoglycemia, then metabolic diseases. Yeah, these are, and children and adolescents, it can be due to congenital heart diseases which are unoperated, or status post surgery, or some still residual defects even after surgery, or valve regurgitations, or ischemic injuries, or failure of single ventricles. Like you see, some especially surgeries when they do for congenital heart diseases, there are two types: definitive surgeries or palliative surgeries. So even if you do some definitive surgery, there may be some residual defect, or there may be some still residual complication which is inoperable. Or if you go for palliative surgery, so palliative surgeries are always done just to give a better quality of life, so that this child is not going to die immediately within next few months. And but palliative surgeries doesn't give a longevity for a long run, and they doesn't completely repair the anatomy. So these palliative, especially when, yeah, one of the ventricle is completely unrepairable, they go for like creating a single ventricle congenital heart defect, where your both pulmonary and systemic circulations are dependent based on the pumping capacity of only single ventricle. So these palliative surgeries, they may be failing at a certain period of time by the child grows into adolescence or whatever. Then cardiomyopathy, Kawasaki and all. So treatment, heart failure treatment. Yeah, the Here we are not going to complete the treatment explaining about congestive heart failure. I'm not going to explain in detail, because my purpose here is like only differentiating, diagnosing cardiac emergencies and making them different from other pediatric emergencies, and just a brief knowledge of how it goes. So we are not going in detail. So the sequence of treatment, like for a cardiac failure, will be oxygen you will be giving, because it is a congestive heart failure and fluid overload, cardiomegaly, hepatomegaly. You tend to give diuresis. If there is a hypovolemia, you do like a bedside dynamic point of care ultrasound and you see completely collapsed IVC and chunky ventricles. Yeah, go for giving 5 ml per kg bolus and inotropic support. Adrenaline versus milrinone. Where you go adrenaline? Definitely when there is a weak myocardium which needs some inotropic support. And where you go milrinone? Definitely when your afterload is very high and your heart is unable to pump against that afterload, you need to bring down that afterload. In order to bring down that afterload, you need a systemic vasodilator. That is the case where you use milrinone. Then ECMO. ECMO is like extracorporeal membrane oxygenation. It is a last resort where child is completely in heart failure and like inoperable. All medical management has failed, and within few hours child may have arrest irrespective of all sorts of treatment. And if you wish to go for some surgical intervention soon ahead, just to bridge between, or if you wish to have some transplant, like so just like some bridging, you can go for temporary ECMO and all. So clinical assessment. So this is just very briefly when we go imaging, chest X-ray, ECG, echocardiogram. Use check for mental status like pulse, perfusion. Then laboratory assessment should be CBC, NT-proBNP, BNP. You check whether, because if it is very highly elevated, it indicates that your heart is failing. So broadly we classify as warm and wet, warm and dry, cold and wet, cold and dry. Yes, warm and wet. Warm is always see peripheral vasodilation. So he needs only inotropic support. And wet, so definitely he is fluid overloaded. So to get out of this wet, you give diuretic. And for this warm, just inotropic agent only if he is hypotensive, or else you can give to decreasing high afterload. Your milrinone will act very good here. And warm and dry, here also because he is dry, avoid diuretics, and he is warm, so even milrinone will be effective here. Cold and wet, definitely cold shock. He is hypoperfusion. He needs adrenaline and he is wet. So he is fluid overloaded. So please give diuretic. Cold and dry. So yes, child is dry, sunken, low pulse volume. Avoid diuretics here. You can give fluid bolus. And he is cold. He needs inotropic. Give adrenaline. So assess response, always check for Krebs, check for hepatomegaly, check for his BP, check for his heart rate, check for the response. So yes, improved, admit to ICU, just maintain. If it is not improved, definitely escalate the support, go for mechanical ventilation or call for a cardiologist help or refer to cardiac center. Then so many patients with left to right shunts present with symptoms, yeah, this we already discussed, which are misdiagnosed as respiratory illnesses. And indiscriminate oxygen therapy should be avoided because oxygen is a potent vasodilator, which we already discussed. So it increases the shunting, it increases QP. So QP again, unnecessarily, if it increases QP more than QS, child may land up in shock again. So this will result increase. So such patients are always pink and in shock. Then we come to rhythm changes. So what are the rhythm abnormalities which can present in pediatrics? So sinus arrhythmia, which is normal, benign condition. Heart rate varies with respiration. This is most common in children, and this is not going to cause any abnormality. Whereas, so sinus arrhythmia, why is sinus arrhythmia? This is just due to that breathing pattern. So during inspiration and during expiration, that vagal tone mediated, that is sinus arrhythmia. Then premature atrial complexes. They are typically benign and common, especially infants. They can occur throughout childhood and no treatment is required. Very good. Then with increased number of patients with repaired congenital heart defects surviving into adulthood who present into emergency rooms, variations of their ECGs associated with underlying may mimic ECG findings associated ischemic coronary disease. Especially very good. See, so once upon a time, few years, few decades before, like 10 years before or 20 years before, these congenital heart disease babies used not to survive longhood, but now situation has changed, drastic change, excellent healthcare. So lot of children with congenital heart diseases are getting repaired within infancy or within childhood, and they are going up getting adults. So the problem is like what we discussed before, even in the hands of best surgeon, 100% correction of the anatomy is not possible. They may land only up to 99% of the correction. So that 1% residual defects may always be there. And that particular defect may even cause that electrical conduction abnormalities. That children may have ECG changes different from a normal pediatric ECG. So these changes, because post cardiac surgery, that myocardium, sometimes post cardiac bypass, they may be having marathon surgeries landing from 3 hours to 9 to 10 hours. So that myocardium might have suffered some permanent injury. So their ECGs may always mimic coronary ischemia changes. So just before labeling some ECG as myocardial ischemia, just try to get the history. Is this a congenital heart disease previously surgically corrected? Then electrolyte abnormalities which can cause ECG changes. Hypocalcemia, lengthens QR interval. Hypokalemia, ST segment depression. And children presenting to ER with possible rhythm issues. SVT remains the most common etiology. Yes, in pediatrics, most common rhythm abnormality, especially tachycardia, is usually supraventricular tachycardia. So, however, SVT itself is not the diagnosis. Yes, definitely. Pediatrician should know that SVT is not the diagnosis. SVT is only a manifestation. SVT is only a manifestation that your heart is having some problem where it is trying to portray to the entire world that it is trying to show outside that I am suffering, I am having some problem. So don't think SVT as a diagnosis, just like as somebody told, fever is not a diagnosis. Fever is only a manifestation. The same way it goes with SVT. So narrow complex tachycardia, wide complex tachycardia. So less than 0.09 narrow complex and more than 0.12 wide complex. So P wave before QRS, always look for that no P wave, definitely, because this is how you differentiate narrow complex tachycardia. If there are P waves, look for sinus tachycardia. If it is varies over time, definitely not cardiac. If there are no P waves, always remember something is abnormal. So no P waves, but with good pulse, BP, pulse pressure, you can straight away go for vagal maneuvers, or you can try getting for adenosine because you are suspecting SVT here. Whereas if child is in shock, reduced pulse, hypotension, hemodynamically unstable, straight away go for synchronized cardioversion, admit in cardiac ICU. And we are not discussing detailed here how you give synchronized cardioversion and all. But yeah, we will discuss that in future sessions. But basic gist is hemodynamically unstable, he needs synchronized cardioversion in SVT. Hemodynamically stable, straight away go for vagal maneuvers, or you can try giving adenosine. If converts to sinus, straight away referred. If it is still persists, call for cardiologist help because he needs further pharmacological intervention, or you may go again for cardioversion and all. Then children with repaired congenital heart disease have surgical incisions which leaves permanent scars which can alter, as we discussed already. In instances of primary atrial tachycardia, administration of adenosine may not terminate arrhythmias. However, the drug can transiently block the AV node conduction and expose the underlying atrial rhythm. Yes, this needs to be understood. This is a very important thing. Like you see, what is the mechanism of action of adenosine AV node blocker? So some primary atrial tachycardia, the moment you give adenosine, it blocks your transmission through AV node. Then what happens is your underlying rhythm get exposed because if your AV node is not blocked, the tachycardia, whatever is firing from atria, even gets conducted to ventricle, and it just manifests as tachycardia, tachycardia, tachycardia. So, but the moment you block your AV node, you were probably underlying atrial fibrillation, it may be, you don't know, but all the time you may be getting, because that atrial flutter or fibrillation whatever is there is being transmitted through AV node, and you may be having that QRS in tachycardia fashion. But the moment you give adenosine, immediately you will try to observe that underlying atrial fibrillation rhythm. You can clearly visualize if you are continuously recording that 12 lead ECG and you give adenosine, your underlying rhythm gets exposed. That's the excellent usage of adenosine. Then coming to SVT, AVRT, AV re-entry tachycardia is the most common form, and it represents the persistence of embryological atrioventricular muscular connection. So yes, it can be pre-excitation or orthodromic or antidromic. Orthodromic is where that pre-excitation goes through AV node. and return through that accessory pathway. Whereas antidromic is excitation goes through that accessory pathway and returns back through AV node. This is antidromic. Then wide complex tachycardia. Definitely, pediatric wide complex tachycardia is a very beautiful topic and very interesting topic, and not so easy to understand. We will deal in detail with wide complex tachycardia in pediatrics in a completely different session. Here is a just a small flowchart which I try to put things in a simpler way. So just look whether it is regular or irregular. If it is irregular, definitely think of atrial fibrillation, which is being conducted through accessory pathway, conduct cardiologist. Then if it is regular, then again think it could be probably your SVT with abnormal conduction blockade, either RBBB or LVBB, and some antidromic AVRT is going on. So this one always think wide complex SVT is always not narrow complex tachycardia. Please remember, SVT can be narrow complex tachycardia or wide complex tachycardia. Narrow complex tachycardia happens only when it is conducting through normally, all AV node and all are normal. But once the conduction becomes aberrancy, it becomes wide complex tachycardia. So here adenosine is the drug of choice, because the problem is predominantly supraventricular. Your drug of choice remains adenosine. Then VT, if it is like ventricular origin tachycardia but good pulse, good BP, just consult a cardiologist how to intervene and all. If this is definitely hemodynamically unstable, straight away go for synchronous cardioversion. Suppose here if it is cardiac arrest, you will straight away go for defibrillation. But hemodynamically unstable, you go for cardioversion. If completely hemodynamically stable but still ventricular origin tachycardia, yes, consult cardiologist, and usually drug of choice will be amiodarone in pediatrics if it is a ventricular origin tachycardia. And this SVT needs to be eliminated here, because before you label your wide complex tachycardia as VT, rule out SVT with aberrancy always. That's the reason we give adenosine as the first drug of choice with pulse in wide complex tachycardia. That's what Pulse has mentioned. Then bradycardia. So bradycardia again can be sinus bradycardia or conduction blockages type 2, type 3 and all. So pediatric sinus bradycardia, if hemodynamically stable, just reassure, you need not do anything. But if it is affecting hemodynamics, yes, definitely go for giving atropine or isoproterenol, glycopyrrolate. These are just pharmacological tries which tries to eliminate that vagal tone and increase the heart rate. But take a cardiologist consultation. He may need transcutaneous pacing. Then blocks, definitely take for cardiac consultations, and if hemodynamically unstable, definitely he needs transcutaneous pacing. Transcutaneous pacing devices are inserted through usually IJV lines or femoral lines, where your electrode is implanted from the transcutaneous line into the heart and externally manipulated with a pacemaker box. Then the most common clinical pre-excitation condition is usually Wolff-Parkinson-White syndrome, and children at any ages can present with arrhythmia. And yeah, this already we discussed. Like, because even in spite of 100% surgical correction, 100% is never possible. It's only 90%, and some residual scar tissue, they are always there, and some complications may happen. So another most important point is computer generated ECG interpretations are frequently erroneous and can cause unnecessary patient anxiety. Yes, most of the time people tend to see, you take a computer generated automated ECG and you will try to read that impression diagnosis, that what that machine has given, ST, elevation, myocardial infarction or some nonsense, it will be coming out. Pediatrics is completely different from adults. So don't depend on your ECG machine, what it is telling. Use your insight, use your medical insights, use your clinical acumen to interpret that ECG. Check for the rhythm, check for the axis, check for the rate. So use your knowledge, just don't depend on the computer generated interpretation. So knowledge to interpret real ECGs is necessary to make adequate decisions and timely cardiologist referrals. So yeah, thank you. We end up this session and we will come up with the second session which deals with cardiac emergencies like infective myocarditis, Kawasaki, and more interested topics. So this is the what we reference use practical approach to diagnose and management cardiac emergencies through Springer. So well friends, so we'll come up with the second session very soon. So any doubts, you can just mail me up or call me. Okay, so thank you.